Good afternoon. We have with us Dr. Dadnendra Moturu, a consultant and HOD of critical care at Aster Ramesh Hospital, Vijayawada, Andhra Pradesh. We welcome you to the Natco Pharma Specialty Studio this afternoon. We look forward to listening, to the advice that you can pass out to your colleagues, those who are associated in the space of critical care and with bacterial resistant treatment. What are the changes you have foreseen in critical care management?
Very appropriate and timely discussion. Antimicrobial resistance is currently the hot topic wherever you're practicing in the world, especially when you're practicing in Asia and India. So, our interest in this topic started with we noticing patients coming to the ICU first time and hospital for the first time and coming with resistant bugs. They're not exposed to hospital or any healthcare services, and they come up to the ICU with a acutely ill state. And the common antibiotics, first line antibiotics that we are giving, WHO class of access drugs, are not working. So we were like, this patient never exposed to the healthcare system. Why is he having resistant bug? So when we analyzed that problem, we found out there was a high prevalence of over-the-counter dispersion of antibiotics in the community. Over the counter. So random pharmacies prescribing beta lactams, cephalosporins for common cold or for headache or for minor diarrhea. So these kind of patterns are making the people come to the hospital with resistance to the first line access drugs. So in that situation, we have in the earlier days started carbapenems, but carbapenems are very precious. We want to spare them. So we had to go for carbapenem sparing medications. So thereon our interest evaluated because we were facing problems every day in the ICU. And now our unit made a policy that we should spare carbapenems.
So I think what I liked is you've gone to the root to understand, the background of this.
Then we have a study published in Nature, 600 pharmacies observational study. I'm the first author of a dispersion pattern of antibiotics in the ICU. And we have analyzed 600 pharmacies, and more than 80% in the state of Andhra Pradesh are dispersing antibiotics without prescription doctors.
I'm sure that is a very, very valuable study.
I'll share it.
What is the message you like to give the young generation ICU doctors, that are in patient care?
Yeah, first things first, to give message, I am itself a young generation coming out, passing out 4 years back. What I want to share with my colleagues is first thing is uh, when you're in a periphery, in a tier 2 town, tier 3 town, and a patient comes in acutely ill to you, uh, and he's having a positive SOFA score, and he's having hypotension, elevated creatinine, and he's having hypoxemia. You sometimes, maybe for the 6 to 8 hours, if you don't see any response with the first generation of drugs, immediately go for carbapenem spares. Immediately go for carbapenem spares if you have a gram negative, suspicion, especially intra-abdominal source. And the number two thing is culture and sensitivity directed therapy. So if you can get a multiplex PCR for the blood or whatever source you suspect as early as possible, that's a very good option in de-escalating the antibiotic therapy. And number three is taking the blood cultures and all cultures before starting the antibiotics. That will help you to get a better result and you can taper down the antibiotics.
Thank you for passing the message to your colleagues. My final question to you is, what is the prevalence of carbapenems in your practice? You mentioned a few areas, uh, and what is the treatment option?
So the incidence of carbapenem resistance is up to 30%. The current, tier 2 towns also we're having 30% because all the first lines are being dispersed even by RMPs. By the time the patient is coming to you, already patient is on third generation, fourth generation cephalosporin or carbapenem for that matter, worse situation. So, to save carbapenem, ceftazidime, avibactam, all these novel carbapenem spares can be used. Ceftazidime, avibactam, tazobactam, whatever you get available at your place.
Thank you so much, Dr. Motoru, for sharing your insights, and we wish you all the best for all the further research that you want to do. Thank you for your time in the studio.